darkness of ignorance and bless us all with the enlightening our knowledge and giving us an extra edge in our way of treating cancers. So for that, I would like to call upon Dr. A.K. Chaturvedi, the past president UPAORI, the complete oncologist in himself. In the past times, there were no separate minor subjects of oncology, and he has been treating the patient as a whole. So we decided to bring this oncology integrated so that let us combine the various dimensions of oncology. So Dr. A.K. Chaturvedi, the owner of Dr. Chaturvedi Cancer Hospital, Private Limited and Research Center, Chaturvedi Gorakhpur. Welcome you, sir. Please take the dais and introduce Dr. Manoj Shrivastav.
Thank you, Dr. Dipti. As you know, today is World Health Day. And this is held to mark WHO Foundation Day, and it is seen as an opportunity by the organizations to draw worldwide attention to a subject of major importance, that is global health every year. Now, health for all implies the removal of obstacles to health, that is elimination of malnutrition, ignorance, contaminated drinking water, and unhygienic housing, quite as much as it does the solution of purely medical problems such as lack of doctors, hospital beds, and drugs and vaccines. Now, as you know, that the non-communicable disease, NCDs, are estimated to account for 63% of all deaths in the country, out of which 27% are from the cardiovascular diseases. And next, respiratory disease, 11%. Cancer constitute 9% of the deaths, diabetes 3%, and others 13%. There is an increase in NCD because of mainly 4 to 5 reasons. Number one, tobacco use, physical inactivity, alcohol, unhealthy diet, and fifth one is HPV virus. Oral cancer is fairly common. It can be cured if found and treated in early stage. A health care provider or dentist often find oral cancer in early stages. And because mouth and lips are easily examined, almost all the oral cancers are squamous cell carcinomas. The oral cancer includes cancer of lips, tongue, palate, pharynx, larynx, and lower alveolus, upper alveolus, and they can be easily treated and diagnosed early. So today's topic is head and neck cancer. And for that, I invite Dr. Manoj Shrivastav, the renowned oncosurgeon of UP and India. He is first MCH from KGMC. He was trained in Tata Memorial Hospital, Mumbai, and Rajiv Gandhi Cancer Institute, Delhi. He had a fellowship from Memorial Sloan Kettering Hospital, New York. He was ex-professor KGMU, Lucknow, and he is associated with so many hospitals. And here also in Gorakhpur, he is associated with Dr. Chaturvedi Cancer Hospital and Kodar Cancer Hospital. He is a very nice surgeon, very meticulous surgery he's got. So now I invite him and take the chair and introduce Dr. Vivekanand Singh, today's speaker. So Dr. Manoj Shrivastav.
Yeah, good evening, everybody. And thank you, Chaturvedi sir, for inviting me and giving on this occasion. Actually, as you know, the cancer is a very common problem now worldwide. But I think the 90% cancer covers only the 4 cancer, especially in our part. Oral cancer, number 1, cancer cervix, cancer breast, and cancer gallbladder. It covers
They are the
90%
major.
cancer.
Yes, very true.
So today's our guest speaker is very renowned and very authentic, energetic head and neck oncosurgeon, Dr. Vivekanand Singh. I know him very well because he was the first authentic ENT surgeon who is doing cancer surgery very well. And he did his MS, I think, from Kanpur. And later he joined the Tata Memorial Hospital for complete 3-year residency course. Then after that, he practiced in Kanpur and then came to Lucknow. So it is a very good, he's a very good person and very, very meticulous surgeon. I know I exposed him a one surgery of CA larynx he did with me. And he put a voice box in that patient. And his patient is very fine. He doesn't mind what is the time is taken for the surgery. But his surgery is very good, no doubt about it. And today he's working as a director of head and neck oncology in Medanta Hospital, Lucknow. So we are lucky. So we are going to hear him the new concepts of head and neck surgery. You know, the concepts are changing day by day. We know the chemotherapy are changing, molecular therapy has come, and target therapy. But the new concept in surgical, especially head and neck, so we will listen to him, what he's telling about what is the new in the head and neck surgery. I am also very interested to listen to him. So it is over to Dr. Vivekanand. Please.
Thank you, sir. Thanks for the great introduction. I'm very happy to see you after a long time. I'm highly thankful to Chaturvedi sir, Dipti ma'am for giving me this opportunity to talk about this topic. And today I'm going to talk about the latest guidelines for the treatment of for treating the oral cancer. First, I want to say that 1A evidence is the systemic review of the randomized control trial, and 1B level of evidence is individual randomized control trial. 1C is all of none study. Level 2A is systemic review of the prospective study, that is the cohorts. Individual is the 2B. Outcome research is the 2C. Systemic review of the retrospective, that is a case control study, is 3A. Individual is 3B. Case series are 4 and expert opinion is 5. These are the level of evidence. Now we will see. For the guidelines of latest guidelines of oral cavity, there is no major change. N0 trial, which came in 2015, in which elective neck dissection versus therapeutic neck dissection in node-negative oral cancer by Dr. De Cruz. And this we all practice in early oral cancer. We do the elective neck dissection. In this trial, they have showed that if the depth of the invasion is less than 3 millimeter, then if there is a less than depth of invasion is less than 3 millimeter, then there is equal benefit whether we do elective neck dissection or therapeutic. But if the depth of invasion is more than 3 millimeter, there is an absolute survival benefit of 12.5%. And beside this, there is a PET-CT scan surveillance post chemoradiation in N2 and N3 patients, which came in 2016. The new 8th AJCC classification came in 2020, in which there is upgradation of the nodal stage, which is extranodal extension. It is come as N3B, which is independent prognostic factor, for which there was a prescription of the adjuvant chemoradiation, which came from the randomized control trial in the 2005. In the 8th AJCC classification, depth of invasion was the important factor, in which more than 1 centimeter is stage 3, and these patients were subjected to the adjuvant radiotherapy. Further, in this, in the cancer of, not in the oral cavity, in the oropharynx, in stage 1 and 2 of CA tonsil, nowadays NCCN guideline is there, which has showed the level 2A evidence in 2018, and they have incorporated transoral robotic surgery or open surgery for the CA tonsil in T1 and T2 stage, whether it is P16 negative or positive. Besides this, what are the surgical changes? Recent practice changing recommendations for the oral cavity is there is a for the surgery compartment clearance concept has came in for the cancer tongue of stage 3 when the depth of invasion is more than a centimeter, or cancer buccal mucosa or RMT when it is a stage 4B involvement, then the compartment clearance is advised for the surgery. For the plastic surgery, besides free flap, we have started the perforator level dissection, and for this we are able to make the bipedal flap of ALT or free fibula. 3D cutting guides for the free fibula, or transoral robotic surgery or endoscopic surgery for the CA tonsil. There is no role of neoadjuvant chemotherapy in resectable cancer. As we know that locally advanced oral cancers, if they are untreated, the survival is only 6 months. And the stage previously in the 7th classification, it was resectable versus unresectable, but now it is changed into the moderately advanced local disease or very advanced local disease. Very advanced local disease is frankly involvement of the skull base, carotid artery, pterygoid plates, or masticator space. But these patients are also comparatively inoperable when the soft tissue involvement is there till the zygoma, till the hyoid bone, or the involvement of the oropharynx, and it was advised by the VM Patel in 2014. Besides the disease, the prognostic factors also depend on the host-related factors, environment-related factors. In the environment, when the total radiation time interval between the surgery and the start of the post-operative radiotherapy, what is the dose of the radiation or chemoradiation, and host-related factor is the performance status of the patient, age, comorbidity, what is the swallowing-related quality of life of the patient, and for the tumor hypoxia and the tumor volume is also important, and what are the surgical margins. These are other prognostic factors besides the staging. If the patient is having advanced disease, the survival is barely 6 months, we are having two options, whether we go for upfront surgery or surgery with neoadjuvant chemotherapy. For about the resectable oral cancers, there is a no, with the help of the Lisicra, Zong, was a phase 3 trial, randomized control trial, in which they have showed that there is no benefit on the overall survival with the help of the neoadjuvant versus upfront surgery in the resectable oral cancer. The benefit is only we choose the patient with good prognosis. That is, chemo responders, they are having better chances of survival, 76% versus 41%. John has also showed that improved survival in the patients with N2 disease who received neoadjuvant, and there is a subset analysis which is showing the benefit of the marginal mandibulectomy, 21% in Lisicra and 47% in Dipti. But the important is we are able to lose these 41% patients in which they are non-responders. Whereas we can able to give them good survival with the help of the upfront surgery. And there is no benefit on the overall survival. Therefore, if the resectable cancers, the take home is we have to go for surgery. This was the CHOGUS trial in which 47% patients were, we were able to do the marginal mandibulectomy. Now for the unresectable cancers, the role of chemotherapy is with the help of the 3 drugs, 2/3 patients are responders. They can be subjected to the radical treatment of surgery with chemoradiation, but we can lose these.
Excuse me, please excuse me. All of you, please mute yourself because it's difficult for the listeners to pay attention and the speaker too. So it's a humble request. Kindly do so. Mr. Varun, mute all, please.
Sure, ma'am.
Please continue.
Yes, sir. In unresectable oral cancers, with the help of the 3 drugs, the chemo responders are 66%. Means 2/3 patients are responders, in which we can go for upfront surgery with radiation, or 1/3 patients are the chemo non-responders, which go for the palliative. We can lose these patients. Then one arm is this, or we can go for upfront surgery with chemoradiation in these advanced, very advanced cases. That is, in these T4B patients, whether the margins are achievable or margins are not achievable. If margins is achievable, what does the literature shows? Lau et al. Has showed that there is no difference was noted between 4A and 4B with regard to the local control, net control, disease-specific survival, or the overall survival. We can see both are the same, whether we had operated the T4A or T4B. That means if we are able to get the margins in T4B, the surgery can be done, because local control is as same as the T4A. And this was the Patel in 2021 also showed in these T4B patients, what is the surgery? Primarily surgical treatment is these very advanced oral cancer squamous cell carcinoma. In these T4B, if we compare, red one is the chemoradiation, green one is the surgery with adjuvant chemoradiation, and blue one is the surgery with radiation. And they have clearly showed surgery with chemoradiation or with radiation is having a better survival probability when compared to the chemoradiation. And also they have compared surgical versus non-surgical management. The survival probability is better in a very advanced T4B lesions. This was the results. Manish Meyer also showed in 2018 what is the impact of the radical treatment on the survival in locally advanced T4A or T4B centers. And he has showed selected surgically treated T4B patients, they are having the same control as the T4A. That is, if we are able to get the margins, even in T4B, they are having a good control similar to the T4A. And after this, in this study, he had showed that in T4B, T4A and T4B, unresectable cancers, they are having survival of 6 months. And if there is supranosed disease, then they are subjected to the chemotherapy. And if the responders are there, surgery with chemoradiation, or if non-responders, the survival is only 8 months. And infranosed disease, so on. Finally, they concluded in this, there were the 135 patients in T4A and 75 patients in T4B. On comparison of T4A and T4B, the 3-year control rate were different, from 49 to 41% and 65 to 62%, with slight higher incidence of distant mets in the T4B, but inadequate cut margins was 7 and 12% in T4A, T4B. When patients with cut margins were considered for analysis, local recurrence rate was similar for T4A and T4B. Finally, he has concluded that surgery should be considered as a primary modality of treatment in T4B, where clear margins are achievable. But because the 3-year survival rate of T4A who received radiation alone was 72%, and whereas it was in 42%, which ensured that the T4B overall survival is having less. Therefore, the benefit of the treatment intensification with the adjuvant chemoradiation should be explored for the T4B buccal cancers. Finally, he recommended that in T4B, supranosed disease, PAL chemotherapy, but when there is involvement of the carotid or skull base, whereas involvement of the pterygoid muscle upper third of the pterygoid, he has advised that we have to go for neoadjuvant chemotherapy. And if the patient is having good response, surgery with chemoradiation, and if no response, then chemoradiation and infra-nose disease upfront surgery. And if these patients, if the margins is not achievable, then no doubt we are not going for surgery. The patient is subjected to the adjuvant chemoradiation. In text 324/2008, there is a benefit of the neoadjuvant in unresectable oral cancers. Overall survival benefit was there between 71 months versus 30 months between T-drug versus 2 drugs. And for the surgical defects, I want to say that we can reconstruct a whole of the mandible. Whole tongue can be reconstructed with the ALT. Larynx are closed primarily. But when we are removing two structures simultaneously, the patient is having great difficulty in speech and swallowing. That is when the disease is involving the floor of mouth or the vallicula. So there is some surgical plastic surgery changes, which I will discuss. Also, I'm going to say that the compartment tongue surgery was advised when the depth of involvement on the preoperative imaging is more than 10 millimeter, that or with the involvement of the extrinsic muscles of the tongue. Then nowadays, some people are prescribing the compartment resection of the tongue, in which all patients were treated, whole of the compartment was removed. In this, T1, T2 patients were excluded with N0, M0, which can be removed perorally. But if the depth of invasion is more than a centimeter or muscle involvement, then they prescribe the compartment tongue resection. In compartment tongue resection, whole of the compartment of the extrinsic muscles are removed. The tongue is removed by the pull-through technique. Both intrinsic and extrinsic muscles are removed from the origin to the insertion, means hyoid bone, digastrix, mandible periosteum, midline, lingual septum, styloid process, stylohyoid muscle from the origin. Whole of the, along with this, lingual nerve, hypoglossal nerve, veins, lymphatics, vessels, lingual arteries, everything is removed in this compartment of the one side. And they have showed, compartment dissection has showed that after 5 years, local control was 16% better with the compares to the standard surgery. Loco-regionally controlled 24% improvement. Overall survival, there is a 27% improvement by the Calabrese. And compartment clearance of the infratemporal fossa for T4B lesions, as advised by Katna and some other surgeons. They have advised this type of surgery, in which they have removed from the eustachian tube to the TM joint to the skull base, foramen ovale, everything was removed in this part. And the indication was when the involvement of the more than two structures of the following. This is when medial or lateral pterygoid is involved, pterygoid plates, tip of the temporalis muscle at the tip of the coronoid, or high masseter involvement, or the retroenteral fat, basically the supranose disease. In these patients, full high ITF clearance was advised by Katna. But if T4B, but with involvement of less than two structures, that were considered with the standard composite resection with wide margins. And the new changes are, with the help of the PMC, we are able to reconstruct 21/8 centimeter, but with the help of the anterolateral thigh, we are able to reconstruct much more wider area, means much more large lesion we can operate and reconstruct with the ALT flap. And this can, we can do up to 30 centimeter by 9 centimeter flap. And the importance is, nowadays we are doing the perforated dissection, in which we are making this ALT bipedal, and even in the free fibula, The skin perforators, we are making bipedal fibula, skin pedal in the free fibula, or we are getting nowadays 3D cutting guide for the reconstruction of the fibula. Just want to show this is the very large defect, and this can be easily be reconstructed with the single ALT flap. In this, mandible and tongue both are removed. The patient will be having great difficulty of swallowing and speech. What we did in this, fibula is there, and this skin pedal distal part was cut and rotated to form the tongue, and bipedaling of the skin pedal of the free fibula like this. One flap is this and another flap is this, and this patient will having a better ability to speak and swallow. This was the outcome. Another case of in this patient, high ITF disease was high ITF disease clearance was done. We can see the medial pterygoid involvement, and lesion is reaching the lower border of the lateral pterygoid muscle. And in this, skull base clearance was done. This is the greater wing of the sphenoid, the foramen ovale. And the important thing in doing this is what I learned. There is a ligation of the maxillary artery behind the neck of the mandible. Behind the neck of the mandible, we can ligate the maxillary artery. I can accept that this can be done by clamping the external carotid artery low down. But here also, with the help of the maxillary artery ligation, the surgery is quite easy because there is no loss of blood. And ligation of maxillary artery in the supranotch area is difficult because there is the disease. Then this site is very good behind the neck of the mandible. And this was a reconstruction with the help of the ALT flap. And these are the cutting guides of free fibula 3D, in which we give the contrast CT scan of the face and CT scan of the leg. And with the help of the computerized model, they make this thing that where we have to cut the fibula and how to align with this thing. So they give us the cutting guide for the mandibular right side and the left side, and cutting guide for the fibula finally. And then there is an aligner plate which they give us, and this is the fibula cuttings. Finally reconstructing the mandible middle third. This is especially helpful. This cutting guide is especially helpful for when we are cutting in fibula in 3 parts. But when the straight segment of the mandible is required, then this can be done without using this 3D cutting guides. But when we have to reconstruct all the part with different angles, then definitely this is very helpful. This is the final outcome. With the help of the 3D cutting guides, we can see the lip occlusion of the lip. In this, the patient was having buccal mucosa operated 5 years back, but now the patient having 2 primaries, one on the tongue and one on the RMT. And this was removed, but this point was very difficult to reconstruct. Probably we thought we are going to use 2 free flaps, but with the help of the ALT, 2 perforators, we use the single flap of ALT, and one part goes to form the tongue and another part goes to form the buccal mucosa. And for about not for the oral cavity, for the oropharynx, nowadays NCCN guidelines 2018 also incorporated the transoral or open resection of the CA tonsil if the tumor is stage 1 and 2, P16 positive or negative, whether positive or negative. Finally, in robotics or endoscopic surgery of tonsil, T1 and T2 means that in this, the plane of dissection is a superior constrictor. From the peroral, we cut the mucosa of the soft palate, just lateral to the superior constrictor at the level of the buccopharyngeal fascia. And this is the line of excision. And the margins we will get 2-3 millimeters. There is a debate about it. What is the margins on the robotic surgery? But when the disease has inside has entered into the parapharyngeal space, this is the inoperable for the transoral surgery. Or when the tumor is crossing midline at the level of the soft palate, the benefit of this peroral or endoscopic surgery, there is no reconstruction is required, and there is only facial artery or lingual artery are at risk, which can be easily controlled at the neck. And if we can, if we are medial to the stellate process, we are not able to go to injure the carotid artery, because it is going to the behind the stellate complex. Finally, I am going to conclude that in moderately advanced disease, resectable surgery is preferred. There is no role of chemotherapy in terms of survival in the resectable cancers. T4B very advanced. If margins are achieved, the surgery is preferred. If margins are not achieved, then neoadjuvant and reassess. Age, comorbidity, post-treatment swallowing are other important factors. Role of chemotherapy in the term of survival in resectable cancers, whether we are using 3-drug or 2-drug. With the help of the recent free flaps, large defect can be reconstructed 3-dimensionally for the functional quality of life. Compartment clearance for cancer tongue, T3 more than depth of invasion more than a centimeter, or cancer buccal mucosa, T4B is advised. And for oropharynx, transoral robotic surgery or open for the CA tonsil are also in the recommendation, which is labeled 2A in the NCCN. That's it, ma'am. Thank you.
And
Yeah,
Dr.
thank you. Thank you. Very good presentation, really. Is in advance, you are operating the so advanced cases and successfully. But one thing I want to ask, what is your success ratio if you are clearance, ITF clearance you are doing, then what is the success? How much recurrences you see?
Actually, I had operated, I think, 10 cases. And what the literature is showing, Dr. Katna's paper, the 2-year survival rate is 50%. Normally, when we are comparing the advanced oral cancers, the survival is barely 6 months on in a year. And if we see the Katna's paper, he has showed the 2-year survival rate of 50% of, I think, 105 patients or 108 patients.
Actually, this surgery, I think in my personal experience, is you are removing so structures and all that, and it is creates a very, morbidity is very high, and as well as recurrences I have seen. So a patient is very morbid. If what you think, it is a patient with all your compartment, you are resecting the whole of the compartment, all the extrinsic muscle, and you are going up to the styloid, everything is you are removing. Then have you experience of such cases, compartment in tongue cases?
Two issues. One compartment resection is tongue, and another compartment resection is buccal mucosa. For the tongue, the advice is when the tissue is depth of invasion is more than 1 centimeter, we can debate that we can leave some part of the muscle, it will be helpful. It is not like that, because when the insertion of the muscle is cut, this is of no use. And when we leave behind some small part of the periosteum, that is also not going to benefit it, because now we can easily construct these defects with the help of the free flaps, free radial or PMMF. PMMF is also very, very useful flap to reconstruct the half part of the tongue. So my say is, whatever the surgeons who are advising the compartment resection of the tongue, they are saying that the residual tongue which we are preserving, that is not going to benefit. Whereas if we are having good compartment clearance, the control rate is better.
Local control is better.
Piazzi's paper, they are saying that loco-regional or survival benefit is there with the help of the compartment resection. From there, because tongue is behaving bad, buccal mucosa is not that much. Therefore, they are advising the compartment resection even in T3 tongues. But in the buccal mucosa, when the patient is having T4B lesions, means the lesions is reaching the skull base or other things, and we are able to do the complete clearance of the skull base in the T4B lesions. The defect can be easily reconstructed with the PMMC or free ALT. In this, there is no great morbidity. if we are operating T4B skull base, we are not adding so much morbidity because the patient is having good tongue, and he will be able to swallow because base of tongue is normal. We are removing the skull base structures, which is not going to give more morbidity to the quality of life post-operatively. Because with the help of the free ALT flap, the reconstruction is going very good in these patients.
Okay. And one thing, suppose if you during surgery, if you found there's some node is badly adherent to the carotids, then what will you do? Do you resect the one side carotid?
Very good question. No. Normally, I think this is frankly inoperable. What I have showed also, if the patient is having skull base involvement or carotid artery involvement more than 180 degree or 270 degree, maybe debate point, but if at all it is adhered to the carotid, we have to go for neoadjuvant chemotherapy, because these patients are not operable at all, and outcome of I think surgical resection of carotid artery is studied in 125 patients, and all of the patients died in 1 year. Therefore, at present, if carotid artery involvement or skull base involvement, frankly inoperable disease, absolutely pal chemo and all, and whatever you want to do. But I want to make my point that if the patient is advanced T4B of tongue or some other thing which we can reconstruct with our large flaps, then the surgery is indicated in those patients. Because this is having good survival, locoregional or overall survival when we compare the surgery in the T4A.
Okay. One question more. Suppose if you are giving the new adjuvant chemotherapy, then after the chemotherapy, definitely the new margin is different. Then how will you decide the margin? You will go to the previous margin or the newer one?
Sir, this is a very great debatable question. Very difficult to answer because I don't know how the tumor is going to behave with the help of the chemotherapy. Because sometimes tumor is behaving positively after chemotherapy, sometimes badly after chemotherapy. The point taken is we have to take the margins which are the worst margins, because if tumor has increased, then we have to increase the margins, and if the tumor has regressed, then I would like to take the previous margins. Whatever the safest zone for the patient, I will go for this. It's very difficult.
Yeah, I agree with you. I agree. Okay, Dr. Vivekanand, very well presentation, and you answered very well. And if anyone wants to ask the question, then please.
I think one is, what is the quality of life after extensive resection surgery? I have answered this question, because in tongue and buccal mucosa, both the things, compartment resection is for stage 3. And stage 3, when we are reconstructing with the help of the radial or the ALT flap, there is no problem. But the problem of aspiration is maybe there when we are operating total glossectomies or that patient. There is compartment resection was advised for tongue of T3 lesions. I am not talking about the extensive resection of the total gloss, hyoid bone. I am not advising those things. So therefore, the quality of life is better in these patients. In your experience, when you have operated T4 cancers, what was the median survival? I had operated 5-6 patients, and the survival is pretty good. Though the literature is showing there is a increased incidence of distant mets. In my 6-7 patients, I have not advised. All are behaving very well. I think more than 2 years or plus. And that's it. We can operate if we are able to reconstruct it.
Thank you very much, Dr. Vivekanand.
Thank you, sir. Thank you.
Okay.
Thank you, ma'am. Thank you, ma'am. Thank you, sir.
मैम आप म्यूट पे हैं मैम, प्लीज अनम्यूट कीजिएगा मैम। Ma'am, you're on mute.
Okay. so I was saying that we have got very bad cases we have seen of the stage 4 operated cases coming here for further treatment and having unhealed and fistulas and scars and ulcers. And still they are not having a very good quality of life. So I feel...
Yeah, correct.
Yeah, so I think initial stages, like it is even in gynae oncology, at initial stages you can operate, but later stages, I think so the other dimension should be better, dimension of treatment like neoadjuvant or localized focused radiotherapy. What is your opinion, Dr. Diksha Chaturvedi? Dr. Diksha, unmute and come forward. Let us hear from you something.
Hello, good evening.
Anything new you want to add up?
Hello, am I audible?
Yeah.
Good evening to all. Actually, in T4B, we are mostly going for palliative cares and radiation and chemotherapy just to support the patient's further quality of life. T4A and all, though it is resectable, it is advanced radiation with concurrent chemotherapy, as sir has already said. So the combined treatment modality will always benefit the patient, but only, of course, we have to see the general condition of the patient at the time of treatment.
Yeah, very truly said. She is my daughter. She has completed her radiation oncology and now she's doing SRship in Bareilly. So I wanted to hear from her because Doctor has gone. So I told her to just come and see what can be done. So it's nice. That is what I had seen. I also accompany Doctor while seeing patients and I've seen really horrible condition of the patient. So I think later stages we should not operate. Palliative, whatever we can do, we should do according to your own understanding. And so now, if anyone wants to ask anything, please come forward or give their own point of views. Dr. Poonam Gupta was there from Poddar Hospital. I think so. She has left. And so let us complete this and conclude this. I'm really grateful to Dr. Manoj and Dr. Vivekanand for such an elaborative, informative, interactive session. And pleased to hear all this on the Oncology Integrated Forum. And thank you all the technical team and the lovely audience, lovely participants. Thank you all. We'll meet next week with a
Thank you, ma'am.
With a new role of radiotherapy or chemo. Thank you so much. Okay. We'll take
Thank you very much.
Thank you.
Bye.